Hello, hi and greetings everyone. Once again, sorry for the inconvenience today. So I have made a complaint for making the Wi-Fi better. I think it will be better by tomorrow. I think tomorrow is a reserve day, so that's why we have some more time. No need to worry about that. So I think I have to retake the session because that was only interrupted in 10 to 15 minutes, and people who are watching the recorded sessions are going to uh, suffer a little bit. So I wanted to really start this thing again. So anyway, so to keep you engaged also, I'm going to start with something different only. So don't worry about that. So we are going to start with the coronary syndromes only, but I just wanted to start something different in the sense like to make sure that the people who are here also gets engaged a little bit. Now I think there should be no break or interference in the video or audio, right? So if you don't feel any interference, just you can give a thumbs up or you can tell yes or no. Yeah. So I think it won't be a problem from now on because it's a proper Wi-Fi now. I don't know. Anyway, somehow it's better. So let us start. Don't want to dissect about that. So as I told you already, any patient who's coming with chest pain, so can be either suffering from a stable angina or probably might be suffering from an acute coronary syndrome. Since I don't wanted to make the people feel bored about taking the small session which I did 10 minutes back again and again. So let us see how to evaluate a chest pain in the first place. So that's what I'm going to start with. So how you're going to evaluate a chest pain first. So there are multiple numerous causes of chest pain, but we need to know the differential diagnosis of each and every patient who comes with a chest pain. So we can divide the chest pain into cardiac causes, pulmonary causes, gastrointestinal causes, which can cause chest pain, and there are numerous other causes that can cause chest pain as well. First, let us start with the cardiac causes, but to start with, I'm going to tell what is the cause that we're dealing with. Then after that, we'll be dealing with what is the type, is there any clinical feature of that particular type of a chest pain that we're dealing with, then is there any investigations that can support our diagnosis to tell that the particular type of chest pain belongs to that particular category. The first one we're going to talk about is the acute coronary syndrome, which is the most important. Remember, almost 1/4 to 1/6 of the patients who come to the emergency department with chest pain will be suffering from an acute coronary syndrome, because this is going to be a real-time threat to all the patients who come to emergency department with chest pain. So you have to be really careful. Any patient who comes with chest pain to the emergency is a potential acute coronary syndrome case. So you should not relax in that perspective, especially when they come to ED. So be very careful. So how they are going to tell? So they are going to tell an ischemic chest pain. So typically they will tell like something called as a substernal pressure, or probably, like they can tell it as a substernal pain as well. You know what do you mean by Levin sign, isn't it? Levin sign is like clenched fist in the middle of the chest. So, and if the patient presents to pain like this, that's typically called as a Levin sign, and that suggests you of a ischemic cardiac type of a chest pain. So whenever they tell that kind of a substernal pressure or kind of a substernal pain, the likelihood of having a acute coronary syndrome is a little high, like probably around 1.5 to 2. So that's what we tell. And that's a really, really important thing. So usually this kind of pain will radiate towards the neck, arm, and the jaw. I think I told you, if it radiates to both arms, it's going to be more significant than if it's just going to radiate to one particular arm. So I told you, if it radiates to left arm, it is specific. But if it radiates to both the shoulders, especially, it's even more specific. The likelihood ratio there is extremely high. So that's why the radiation is going to be really, really important in that perspective. And at the same time, you should know what are the things that will tell you it's a non-cardiac chest pain also. That we'll be discussing subsequently. But more often, this will be associated with severe sweating, diaphoresis, acute coronary syndrome related kind of a chest pain. So the likelihood of the chest pain being acute coronary syndrome is extremely high, especially when it is NTG non-responsive. For example, if the pain is not responding to NTG, as well, the patient is known CAD patient. In that perspective, the pain is not responding to nitroglycerin, that short-acting nitrates, the likelihood is even more higher. Or if the patient is having hemodynamic instability. So the patient is having pain, at the same time patient is having hemodynamic instability. If the patient is having long duration chest pain, like more than 15 to 20 minutes. So that increases the likelihood of having a acute coronary syndrome. Or if the patient is having a prior episode of a myocardial infarction, so in all these settings, your likelihood of having an acute coronary syndrome is going to be extremely high. So of course, the first investigation that you're going to do is an ECG. Can anyone tell how fast you should do electrocardiogram when a patient is coming with a chest pain, or when someone reaches out to a patient with a chest pain, a medical personnel, how fast you should do an electrocardiogram? How fast you should do an ECG? Yes. So there is something called a chest pain to ECG time. It should be done within 10 minutes. So that's a standard number that you need to know. This is called door to ECG time or chest pain to ECG time. So that is within 10 minutes. That's a very important question as well. So you should do this. The first investigation that you're going to do. And of course, the changes that you will be encountering in acute coronary syndrome is the STT changes. That's what you're going to see. Either it could be an ST elevation, hyperacute T waves, or probably even a ST depression, T wave inversion, Q wave formation. You can see a lot of stuff. And the second investigation that we generally prefer is doing a troponins. We'll be discussing more on the troponins in some time. So I'm going to have an interactive discussion on troponins in some time. So these are things that will tell you that the patient is having an acute coronary syndrome, and in short. And the second thing is the second cardiac cause is going to be the pericarditis, or as I told you multiple times, we have discussed already, that is myopericarditis. So I can write it in the same setting. So remember, isolated myocarditis may or may not cause a chest pain, but myocarditis surely will cause a chest pain. So let us see what will happen in pericarditis. Pericarditis usually produces kind of a sharp pain. They won't produce a typical ischemic pain or a substernal pain. They'll produce more of a sharp pain that will generally radiate to the trapezius. We discussed this fact already. This is a very important question that's been asked multiple times. They're going to radiate to the trapezius in general. And remember, one important thing about this pericarditis chest pain is the fact that it will increase with respiration because of the contact of the heart with the pleura and the pericardium with the pleura. So they're going to increase with respiration. So you should not confuse with the pleuritis kind of a pain. And at the same time, it's going to decrease on leaning forward portion. This is a very, very important point. I'll tell you why this is important, because it's one of the features of benign chest pain. That's why. So especially when you're leaning forward, if the pain reduces, that's suggestive of pericarditis. And clinically, if you're speaking, you might see a pericardial rub on auscultation, but this is a very difficult thing to pick up most of the times. And it's very subtle more often. So the most important things that will be considered in the exams is the increase with respiration and pain that is decreasing with leaning forward position. And of course, I'll be taking the ECG, and you will be knowing what are the ECG changes. I'll be seeing ST elevations, which are typically mentioned in the textbooks as global, but as I told you, very commonly pericardium will be affected in the inferior and the lateral zone. So very commonly you'll be seeing the pericarditis in inferior and lateral areas of the ECG as ST elevation. So usually, but when you're going for exams, you think about a global or a diffuse ST segment elevation. Along with that, we know there are going to be PR segment depression. So I can write it here, which we have seen already yesterday. PR segment depression, and at the same time they might have something called a TP segment downsloping. That's what we refer to as something called spottic sign. And all these changes can be a mirror image. I told you this is a very important point as well. Mirror image findings can be seen in AVR, which means you're going to see some different and opposite changes in AVR. Clear? This is how pericarditis is going to present. Now, if it's isolated pericarditis, troponins are supposed to be extremely normal. So in pericarditis alone, troponins cannot elevate because there should be some element of cardiac damage to produce elevation of the troponins. If it's going to be a pericarditis isolated, definitely your troponins will not be elevated. So you can be very sure about that. But remember, if there is an associated myocarditis, then the picture might completely change. Suppose if there is an associated myocarditis, I'm writing in bold letters, because you are encountering a myopericarditis in that setting, you will have all these features, whatever I told you, but there are some things which can be variable. Like for example, patient may get heart failure symptoms that can be associated. So because myocarditis can produce heart failure symptoms, and the troponins can be elevated in this setting if the patient is having an associated myopericarditis, because myocarditis definitely will damage the heart and you can get a positive troponin. So you have to be a little careful. Many times it's very difficult to differentiate myocarditis from an acute coronary syndrome. Only in coronary angiogram you will be able to make out a very good difference. If the coronary angiogram is normal, then we'll think about other causes. Otherwise, whenever in doubt, always think about an acute coronary syndrome as a possibility. Then there is something called an aortic dissection. We have a separate discussion on aortic dissection, so I'm not going to discuss in detail about that. Can anyone tell what will be the pain in aortic dissection? So how the pain will be? So we describe that pain as a tearing type of a pain, and or you can tell it as a knife-like pain. So stabbing, tearing, knife-like kind of a pain. Okay, that will radiate to the back, especially to the interscapular region. So that's where they're going to radiate. And if you see this in the exam, so that radiation to the back and the tearing kind of a pain or a knife-like kind of a pain, so then you typically think about something called an aortic dissection in that setting. And additional features that you can get, and because of that, if you want to tell that this patient is having a high risk of having aortic dissection, is the fact that this asymmetric pulses, which means your pulses will be different in both arms, and asymmetric blood pressure. The blood pressure is different in both arms, especially by more than 20 millimeters of mercury is highly significant. So in that setting also, you can think about having a aortic dissection. Many times, if the chest pain is associated with the focal neurological deficit, please understand this is a very high likelihood for aortic dissection whenever chest pain is associated with focal neurological deficit, especially chest pain that is associated with a hemiparesis or some weakness or a stroke-like feature. So in that setting, there is a high possibility of being a aortic dissection in this setting. And as far as the investigation is concerned, chest X-ray can be done as a primary investigation, but not much useful if you suspect a dissection straight away. But it will show something called a widened mediastinum. That's a very important question as far as exams are concerned. And as far as the other imaging like CT, MRI is concerned, these are the best, and they can show the lumen. So you will see something called a false lumen. We'll be discussing about that in detail. So these are the keys in exam to tell, like these are the standard points in exam to tell that this patient is having something called a aortic dissection. So we are done with the 3 cardiac cause of chest pain. Then we are moving on to the respiratory cause of chest pain. So to start with the respiratory causes, we have pneumonia to begin with. So from now on, I'm going to write only PNA for pneumonia. So hereafter I write PNA, it always stands for pneumonia. You can take it for granted. So pneumonia, clinically the patient will come with fever, plus or minus chills. They will have sputum production. They will have cough. And they might have kind of a pleuritic kind of a chest pain. Whenever a pneumonia patient gets chest pain, it will be a pleuritic kind of a chest pain only. You know how pleuritic kind of a chest pain comes. It's going to be typically increasing with inspiration, and a particular portion, if you press the stethoscope, that area will have pain on pressing the stethoscope. Yes, it's an inspirational pain, but it can happen in pericarditis also. But anyways, so the same thing can happen in the setting of a pneumonia also. And examination wise, you will be getting that characteristic crepitations or characteristic crackles, and typical diagnosis chest X-ray or any other imaging where you'll see an infiltrate in some area, or probably you can see a typical consolidation. So this is how you're going to take out a pneumonia. We have a separate discussion on pneumonia later on, so don't worry about that. So then they can get a simple pleuritis. Pleurisy is extremely common in the setting of a viral infection. Yes, you can write bronchial breath sounds also. Yes, and most often you'll get a tubular kind of a bronchial breath sound if you want to be precise. That's what you're going to get. And in a pleuritis, once again, it's a sharp kind of a pain like pericarditis only. As I told you, it's going to increase with inspiration. And at the same time, pleuritis kind of a pain can be associated with something called a pleural rub. But very difficult to pick up all these things unless and until you are looking exactly in the place where there is a pleuritis. So you need a very good clinical examination skills. Anyway, so this is going to be pleuritis, and you don't have any much investigation to think about pleuritis. Every investigation is going to be negative only. And you can have a pneumothorax. Pneumothorax again produces a pleuritic kind of a pain only, which will be sharp in nature. And at the same time, pneumothorax, most often it will be extremely sudden onset. And when you do an examination, there is going to be reduced breath sounds or absent breath sounds on the involved side. And at the same time, you will see something called a hyper-resonant note on percussion. Hyper-resonant note on percussion on the involved side. So investigation-wise, you can diagnose with a simple chest X-ray where you will be seeing a hyperlucent area. Hyperlucent area with decreased or absent Bronchovascular markings. Whenever I write BVM, it means bronchovascular markings. So in that area of hyperlucency, you will not have any bronchovascular markings, but plus you will see the collapsed lung border. I'll show you the images. Don't worry about that when I'm discussing about pneumothorax in the pulmonology. So you will see something called a collapsed lung border. So apart from the collapsed lung border, everything will be hyperlucent, and you'll be not seeing any bronchovascular markings in that zone. This is very characteristic of a pneumothorax imaging finding. And apart from the pneumothorax, you can have some other pulmonary causes like pulmonary embolism, which is also known to produce a kind of a chest pain, which will be pleuritic in nature as well, which will be sharp. And the pulmonary embolism can happen suddenly or can happen in a subtle fashion, but usually only sudden onset pulmonary embolism will result in development of chest pain. Chronic thromboembolic pulmonary hypertension is unlikely to cause chest pain, except for the fact they can get a mild chest pain due to the dilatation of the pulmonary artery because of chronic pulmonary hypertension. And clinically, you will diagnose if the patient is having unexplained dyspnea. I told you multiple times in the past, unexplained dyspnea, and you will have paucity of clinical signs, which means you will examine the patient, but you will not be able to find anything. Whenever you get this kind of an unexplained dyspnea in a patient, that the patient is having increased respiratory rate, tachypneic, but there will be paucity of clinical signs, which means you are not able to find out any much clinical signs. Everything looks, okay to you, but still the patient is complaining of dyspnea. Don't diagnose anxiety or any other rubbish diagnosis there. The first thing that you have to rule out is your pulmonary embolism. And of course, they will have tachycardia as well, which is a very, very common entity in the setting of a pulmonary embolism. If you take an ECG, you can see a variety of changes, including sinus tachycardia, which is going to be the most common change. And you can see T-wave inversions, especially in V1 to V4, or you can see the classic S1 Q3 T3 pattern. Paucity means, that's not pansity, that's paucity. Paucity of clinical signs. Paucity means, paucity means, you cannot see anything much. That's all. Clinical signs will be relatively absent. That's what I meant by paucity. Okay, then you can see right bundle branch block or right axis deviation. So all these are also very characteristic feature of a pulmonary embolism, which I have been discussing from the past. And of course, the gold standard investigation will be doing a CT pulmonary angiogram. This is supposed to be the gold standard as of now. Very important investigation, which can show the pulmonary embolism. Apart from that, you have multiple other investigations like VQ scans and all. We don't really want to know about that. And you can get increased troponins. It's not like troponins will not be increased. I have a separate discussion on what are the conditions that will increase the troponins, which we'll be discussing after some time. But right now, increased troponins can also happen in the setting of a pulmonary embolism. Okay. Usually, whenever you have an increased troponins, irrespective of the disease, I told you, it is severe. That's all. It's a severe pulmonary embolism, irrespective of the disease. Then the next one is pulmonary hypertension, which itself can produce a chest pain. That is because the stretching of the pulmonary artery sometimes can result in chest pain. And most of the times, they will get an exertional pain similar to that of an angina. And most often they will have dyspnea on exertion. I can write exertional pain and dyspnea here itself. So exertional pain and dyspnea, that's very characteristic. And they can get syncope as well. One of the important differential diagnosis of syncope is pulmonary hypertension. So they can get CTPA, means CT pulmonary angiogram. Clear? Syncope. So syncope is a very important sign of a pulmonary hypertension as well. And at the same time, if you do some investigations, ECG will show right ventricular hypertrophy. That's very common in the setting of a pulmonary hypertension. And at the same time, they can have reduced saturations in ABG, reduce SaO2 and reduce PaO2 in the ABG. Very characteristic. And it is a chronic condition, so you have to really diagnose. And echo also can diagnose to a very reliable way that there will be increased pulmonary artery systolic pressure. When I tell PAS, P stands for pulmonary artery systolic pressure. So that will be increased. And right ventricular systolic pressure also will be increased. And we can look at a lot of other entities like TAP-C to look at the right ventricular dysfunction, which is not important for you at this setting. So echo can tell you that the patient is having a pulmonary hypertension. And of course, once we have discussed on the pulmonary causes, then it's better to go for the gastrointestinal causes of the chest pain. So what are the gastrointestinal causes? The most important is the reflux disease, GERD. Once upon a time, it is believed to be the most common cause of chest pain in the emergency. Right now, even though a lot of studies have questioned the value of that most common kind of a thing. So anyways, for exam purpose, you can understand this is the most common cause of chest pain presentations to the emergency. So most of the time, it can be, like mimicking, or it can be concealing the myocardial infarction. So GRD can be present on top of myocardial infarction, or myocardial infarction can come on top of GRD, or GRD can mimic a myocardial infarction. So it can happen in any way. So don't take for granted that the patient is having GRD alone, unless and until your ECG and other findings are telling you that the patient is not having a cardiac chest pain. So most often GRD patients will tell that the patient is having a substernal burning kind of a pain. So and most of the time they will be having something called as a water brush. You know what do you mean by water brush? That sudden movement of acid back to the mouth, which will produce something called as an acid taste, or a metallic kind of a taste you will get. That's characteristic of water brush. Everyone would have been aware of this water brush, because at some point of time we will get this kind of GRD, especially when you eat too much and when you lie down immediately, you can get this kind of reflex. And of course, the pain will be increased by meals, and that's very characteristic of a GRD. It's increased with food, and it's increased with lying down posture. When you are lying down, the reflex is going to be very high, and it's going to be decreased by your proton pump inhibitor. So this history is the patient will tell. PPIs or antacids, when they take antacids like sucralfate or aluminum hydroxide, it will reduce. So decrease with PPI or decreased with antacids in that setting. So how will you diagnose? Of course, typically you cannot really diagnose based on EGD, but the first investigation you do is esophagogastroscopy. I mean, let me tell you that again. When I write EGD, it's esophagogastroduodenoscopy. That's what I'm going to tell. Clear? Esophagogastroduodenoscopy. So, but remember, this is the first investigation, but still, you're not going to get anything out of it. Reflex is something which cannot be diagnosed, but EGD scopy is important for diagnosing esophagitis due to GERD. It can pick up only esophagitis, but esophagitis is seen only in maybe 10 to 15% of the patients, which means it's not a very sensitive investigation, even though we do first, the scopy is what the first thing you do. But the confirmatory technique is the 24-hour pH monitoring, which you can do if you want, but this is considered to be the best investigation. Which again, if possible, I'll tell you in the gastroenterology section. So if the pH is less than 4, for more than 4% of the time throughout the day that you're monitoring, then you can confirm it's a gastroesophageal reflux disease, GRD. So, but remember, first investigation we do is always the scopy only, the EGD scopy. And it can happen in the setting of an esophageal spasm. So most of the times in esophageal spasm, patient will have something called an substernal pain, which can mimic a myocardial infarction once again. And the clue is the fact that it will increase with swallowing. Clue is the fact that it's going to increase with swallowing. So that's a big clue as far as the esophageal spasm is concerned. Because I mean, more often it will be present like a dysphagia. So why we do EGD scopy first is because 24-hour pH monitoring, even though it's considered to be best investigation, it's more invasive and less complaint. It needs admission to the hospital. It increases the cost of the, overall treatment. And at the same time, it's not very specific as well. Even though it's sensitive to pick up the GRD, it's not very specific investigation. So that's why we don't do 24-hour pH monitoring. At the same time, when the patient comes with GRD, you don't really have only GRD. You might have other problems, like you can have an esophageal web, you can have probably even a cancer in the esophagus that can be concealed, and the patient might be coming with the GRD kind of a picture. So that is the reason why scopy is done for a variety of other reasons, not to confirm whether the patient is having GRD or not. To confirm GRD, so the scopy is a very poor investigation. But if you want to rule out other things at the same time, other lesions like peptic ulcer disease, for example, I can confirm whether H. pylori is there or not. So for other reasons, we can do endoscopy. So that's a very good investigation in that setting. That's why we do EGD first. to rule out structural reasons. Then you can do a 24-hour pH monitoring. For say, let us understand the patient is having some structural lesion, and how will you do a 24-hour pH? How will you put a catheter? So when you put, it might coil on the top of the structural lesion itself. So first you confirm there is no structural lesion. That's the reason why you do EGD first. And as far as esophageal spasm is concerned, it's going to increase with swelling, and of course it's going to decrease with nitroglycerin or any calcium channel blocker like verapamil or diltiazem. That's why we use NTG and CCB as a treatment for esophageal spasm. And of course, the diagnosis will be made through manometry. Manometry is the way to go. So that's where you're going to make a diagnosis. Endoscopy may or may not show changes, but manometry is the first line and the definitive investigation for diagnosing esophageal spasm. And then you can have other problems like Mallory-Weiss tears. You know what do you mean by Mallory-Weiss tears? We'll be discussing about this in the hematemesis section also. But Mallory-Weiss tears is nothing but an esophageal tear. But remember, this tear is always partial. It's not a complete tear. That's the most important point. It's a partial tear in the esophagus that more often presents with hematemesis rather than a chest pain. They might have a chest pain, but more often they have hematemesis. Very common in alcoholic patients. Best diagnosis is through best diagnosis through endoscopy. You have to do an EGD-scopy. Endoscopy is the best way to diagnose this Mallory-Weiss tears. And then you have Boerhaave syndrome. I think the spelling might be wrong, but I really don't know the correct spelling. Boerhaave syndrome. And this is due to esophageal rupture, not tear. So when you tell esophageal rupture, it's a full thickness tear, full or a complete tear. All the layers of the esophagus are teared, which means this is going to cause a pneumomediastinum. And that is the reason for the chest pain, and that's where the problem is. Most of the times, clinically speaking, you can palpate this mediastinal layer. Palpate this mediastinal layer. At the same time, they can produce subcutaneous emphysema. And very importantly, in exams, they'll ask something called a Hammond's mediastinal crunch, which can be heard very rarely, but that's a very important sign as far as exams are concerned. So this is the key here, which means Boerhaave syndrome is going to present more of a pneumomediastinum, whereas Mallory-Weiss tear is going to present with more of a hematemesis. So chest pain, Boerhaave, hematemesis, think about more of a Mallory-Weiss. Even, Boerhaave also can produce hematemesis, but less likely. But Mallory-Weiss cause hematemesis more compared to that of the Boerhaave syndrome. But remember, in Boerhaave syndrome, you cannot do an endoscopy because already the esophagus is ruptured. So the diagnosis will usually come from a CT scan. If you see the mediastinal air along with small edema or tear in the esophagus, then you can think about a Boerhaave syndrome in that setting. So remember, pneumomediastinum is not going to happen only with Boerhaave syndrome. It can happen with a variety of causes. Even a barotrauma can cause a pneumomediastinum. Like for example, if you're giving a positive pressure ventilation like NIV for a long time or elective intubation for a long time, so barotrauma also can result in development of a pneumomediastinum. So pneumomediastinum itself has many different diagnoses and DDs are huge, but one of the DDs of pneumomediastinum is esophageal rupture in the setting of a Boerhaave syndrome. CT is the definitive diagnosis. If you really want to do, you can even go for a contrast study like gastrographin analysis can be done, where you see the gastrographin leak from the esophagus. You can think about a esophageal rupture. But usually in a routine setting, be practical. We always do a CT as the first line investigation to diagnose a esophageal rupture, Boerhaave syndrome, that is pneumomediastinum as well. And we have a peptic ulcer disease which can produce chest pain, which can mimic a chest pain. The last sign is Hammond's mediastinal crunch. That's what we're talking about. So if Abraham is asking, what is the last signs? Hammond's, HAMMAN, Hammond's mediastinal crunch. It's a crunching sound during each systole and diastole of the heartbeat because of the pneumomediastinum. Number 13 is peptic ulcer disease. PUD always stands for peptic ulcer disease. Of course, it will cause more of an epigastric pain rather than a chest pain, but the patient might be confusing this epigastric pain for a chest pain. And you can get a right upper quadrant pain also if it's a predominant duodenal ulcer, but very common is the epigastric pain that the patient is going to tell. And of course, it will reduce with antacids and PPIs. And nowadays, being, like the proton pump inhibitors are available over the counter, and you can ask any patient, with peptic ulcer disease, they will be taking sometimes for years together daily, because unless and until they take the PPIs, they feel that the pain is always there. So it's such a over-abused drug, this proton pump inhibitors, and rarely they can present with hematemesis, that is gastrointestinal bleeding. It doesn't. Why I'm writing bleeding is because it doesn't only cause hematemesis; it can cause melena also. We know that upper GI bleeding can present with either hematemesis or they can present with melena. Lower gastrointestinal bleeding usually presents with hematochezia only. We know that, or a bleeding PR. That's how they come. How you are going to diagnose a peptic ulcer disease? Of course, you are going to do EGD, that is endoscopy is the way to go. Plus, definitely you have to do H. pylori testing. H. pylori testing, very commonly in our country and in Western countries, we do something called an RUT. Everyone knows what you mean by RUT, that is rapid urease test. So very commonly done test. This is a spot test. If a rapid urease test is positive, we start with anti-H. pylori drugs also. And we'll be discussing about anti-H. pylori drugs later on. That's rapid urease test, which is the first line test done in our country right now. It's a spot test. Remember, currently we follow something called a test and a treat strategy. In the sense, like, if your test is negative, you should not treat it. If test is positive, then only you should treat it. There is no role for empirical H. pylori treatment. That you have to have a very clear thought in your mind. And at the same time, there is one more thing here. Even though I told for GRD, you do a esophagogastroscopy. If the patient is having only GRD, will you do a H. pylori test? Yes, I will do a H. pylori test. But whether you will treat if H. pylori is positive or not, what is the answer? In a GRD, whether you will treat for H. pylori or not, in an isolated GRD. It's controversial, but I mean, if you're telling no, you should substantiate why you're telling no. So Riju told no, Sankhya is telling no. So why you're telling no? Why you're substantiating? I mean, H. pylori actually reduces the acid secretion. To be honest, it's not protective in the sense. It's going to cause a lot of other troubles. But for GRD alone, H. pylori may actually give a little bit of protection, like what you said, because of the atrophic gastritis they're going to cause. They're going to cause reduced acid secretion. Because of that only, like, you might get a little bit of protection. But again, it's a very controversial thing whether to treat that or not, because H. pylori over a long period, it might cause some issues. So whether to treat it or not is a question. But it's been a commonly proven thing that if you treat H. pylori in a patient with the isolated GRD, the GRD generally worsens after that. So probably that is the reason why it's currently controversial. But if you want to really know for exams, yes, you don't really want to treat it. H. pylori is considered to be protective for GRD. So you don't generally treat them. So after the peptic ulcer disease, then you have the biliary disease. Usually they produce more of a right upper quadrant pain rather than the true chest pain that's going to produce. Most often they'll be associated with nausea and vomiting that will be increased with fatty food. So when you eat a fatty food, the nausea, vomiting, pain, all these things will be increased most of the time. And of course, the diagnosis is based on ultrasound. Cholecystitis, cholelithiasis are excellently diagnosed by ultrasound. Okay. Then we have another disease, that is pancreatitis. Acute pancreatitis can be diagnosed in a variety of ways, but usually they'll produce a central abdominal pain, plus or minus epigastric pain, more than the chest pain, but very rarely it can come to the chest level also, but more importantly, it will radiate to the back. So remember, chest pain radiating to the back is mostly aortic dissection in exam, and abdominal pain radiating to the back is predominantly acute pancreatitis as far as exams are concerned, which we know very clearly. And plus or minus, you can get the classic signs, which is very rarely seen, like the Gray Turner sign, Cullen sign. So, of course, every medico will know what do you mean by Gray Turner sign and what do you mean by Cullen sign. No, don't tell. And these are very rare signs that doesn't have real value in the clinical practice. Only for historical importance, we are still learning these signs. And diagnosis is made through the pancreatic enzymes amylase and lipase, even though lipase is considered to be more specific compared to the amylase. If you're doing an amylase, you have to check for the pancreatic versus the salivary amylase. In that setting, amylase can be a little specific if the pancreatic amylase is elevated. But apart from that, amylase is less specific if you do as a whole, and lipase is going to be relatively more specific. And lipase increases are considered to be pancreatitis most of the times if the patient has abdominal pain. Then, of course, the best diagnosis comes from this CECT. Initially, we do a plain CT only, but later on, around 72 hours, we do a contrast CT to assess the severity of the disease. CECT may be asked, but the first initial stage, we'll do a plain CT. Later on, at 72 hours, around we do a contrast CT. That's called a Balthazar grading to look for the severity of the pancreatitis. So that's different. We'll be discussing later on. So pancreatitis. Then, of course, you have some musculoskeletal cause of chest pain or other miscellaneous cause of chest pain are there. Like, for example, you can get a costochondritis. Costochondritis. Yeah, Teat syndrome is an idiopathic costochondritis. That's what we call as Teat syndrome. If you don't have any other cause for costochondritis and if you get an idiopathic costochondritis, that's called a Teat syndrome. Remember, Teat syndrome is often associated with swelling, erythema, and local tenderness and pain. So many times in India, it's not that common, but in Western countries, especially in white population, Caucasian race, this kind of Teat syndrome is common where they come with swelling of the costochondral junction, especially the second, third costochondral junctions are most commonly involved. Second, third are most commonly involved, and they can be having swelling, tenderness on palpation, and erythema also over the costochondral junctions. And very commonly, there will be females compared to that of the males. And if it's idiopathic, then only you should call it as a Teat syndrome. If it has a cause, then fine. If it has a trauma and all these things, then it's fine. If it's idiopathic, you're going to call it as a Teat syndrome. So whatever, my spelling will be sometimes bad. I'm like, forgive me for that. But anyways, I just want to tell you what are the points that are important. If idiopathic, that is what we call it as something called a Teat syndrome. Usually it's very simple to understand because you get a clear-cut swelling that has a swelling, tenderness, and erythema in the local area. So of course, you're not going to think about a cardiac chest pain in that perspective, and it can be reproduced on palpation. You can do MRIs to find out, but usually it is not necessary. It's a clinical diagnosis. If you really want to confirm where the exact problem is, then in that setting, you can probably prefer an MRI, but it's not really needed. And many times herpes zoster can come as a chest pain. I didn't really believe unless until I entered into clinical practice because I thought how herpes zoster can be missed. I've seen a lot of times where patient tell some kind of a chest pain over here and here, especially elderly patients like 70, 80 plus who are having a little bit of dementia and where the caretaker is also not able to examine the patient properly. Once I remove the t-shirt and see, or remove the shirt and see, I can see a clear cut of a dermatomal involvement in the thorax with regards to the zoster. So zoster is sometimes a hidden cause of chest pain. Yes, we are talking about shingles. That is zoster, varicella zoster or herpes zoster. You can call it in any way. Most of the time, you will have a unilateral pain, which will be extremely intense in nature, and it will be causing pain for a longer period of time in the form of post-herpetic neuralgia also. Sometimes, not all the times, sometimes the pain may happen before the onset of the rash. So that is where the confusion is going to be. So it's going to be unilateral, but sometimes, not all the times, pain can be starting before the onset of rash. So that will give rise to confusion. If you see rash, then that's not a problem. If the pain comes before the rash, it's going to be a big problem. And the problem with this is they can go for something called post-herpetic neuralgia. Can anyone tell what is the definition of a post-herpetic neuralgia? How long the pain should be there even after the zoster has resolved to develop post-herpetic neuralgia? What is the time period? So if the pain persists for more than 30 days, more than 1 month, so that is what we call it as a post-herpetic neuralgia, more than 30 days. Clear? So that's the clear-cut definition of post-herpetic neuralgia. If it's within 30 days, then it is called a herpetic neuralgia only, not a post-herpetic neuralgia. But after 30 days, if you get, that's a post-herpetic neuralgia. And you don't have any diagnosis, specific diagnosis for that. You're going to only do a clinical diagnosis because that will be a typical dermatomal kind of a pattern will be there. That's relatively specific for it. And it's a clinical diagnosis. You don't have investigations. And apart from that, you have anxiety finally, which can produce a kind of a chest tightness. So, especially when the patient is getting a panic attack kind of a thing. So they produce kind of a tightness in the chest. They can produce a kind of a dyspnea sensation. It's not real dyspnea. they get some kind of a dyspnea sensation. And most of the times this will be associated with other somatic symptoms. Like they will be telling GI symptoms. I mean, you would have studied in psychiatry. How will you find out a somatoform disorder? You can get a GI symptom, you can get a respiratory symptom, you can get a cardiac symptom, you can get a reproductive symptom. You can get many symptoms. Associated somatic symptoms may be there. As far as anxiety is concerned, panic attack is different. Panic attack is something that happens when the patient is going to get scared, or they're going to fear in an environment which has no apparent danger. So I'm sitting here, I don't see any danger here. Suddenly, if I get palpitations, dyspnea, and I'm feeling there is a sense of danger in a situation and environment where there is no apparent danger, that's what we're going to call it as a panic attack. So that's a little different. Both can produce kind of a chest pain. So I'm commonly putting it under anxiety. And there's no much investigation. It's only clinical completely, even though we have to rule out other causes like thyrotoxicosis and all. That's a completely different list that you have to rule out. But still, like that's anxiety, which can cause a kind of a chest pain. So we know that we have multiple differential diagnoses for chest pain, which we have been discussing for the last half an hour. So right from the acute coronary syndrome to your pulmonary causes, to your gastrointestinal causes, to your cardiac and non-pulmonary gastrointestinal causes like musculoskeletal causes. All these things we have discussed. So how will you approach a chest pain? So that's the next question. If the patient is coming with a chest pain, what are you going to do? So patient came with a chest pain and came to the emergency department. How will you diagnose? Abhirami is asking how to diagnose chest pain if it occurs before the rash. It's quite difficult. So it's a diagnosis of exclusion, and you have to wait till the rash comes. Nothing can be done otherwise. So you have to make sure that it's not a cardiac cause of a chest pain or any other cause. You take an ECG, do a tropan, and do a chest X-ray, then that's fine, not an issue. So how will you approach a chest pain in the emergency department? To approach chest pain in the emergency department, you need a focused history, in the sense like you should not ask the history like what you ask in your exams. It should be like within 2 minutes, 3 minutes, you should ask the necessary history. So prior MI, the patient has been gone for any surgery recently, if the patient has been immobilized. So there are some crucial histories that you have to ask. Very few points are there, depending on the particular type of the patient. Should have a quick history, not a very detailed history. And I'm going to do a targeted examination. So again, examination should be extremely targeted. For a chest pain, I need not really do a complete CNS examination like cranial nerve examination and all. So whatever the patient's symptoms are there, depending on that, I'll be doing a focused, quick clinical examination. Most of the times, as far as the history is concerned, as far as any pain is concerned in the history, you will be having something called a Socrates approach. Have you heard about that? If you have heard about that, then we can move on. Like what is Socrates approach? Do you know or not? Socrates approach. Yes, same thing. Site, onset, character, radiation. Yes, same thing. So you do some kind of a Socrates approach. So that's fine. So once you have done with the targeted clinical history and the targeted clinical examination, of course, you need to go for a ECG. The standard 12-lead ECG should be done, and you know very well it should be done within 10 minutes. That's the standard of care right now. So within 10 minutes, you have to do a electrocardiogram. Plus or minus, you can go for other investigations also, depending on the examination and the clinical finding that you're trying to get. So what are the other investigations that you are going to do? In the form of troponins. Definitely, I might be doing probably a chest X-ray if needed. Depending on the patient's presentation. Again, if I think it's probably a pneumothorax, or if I think it's probably an aortic dissection, but low probability disease, then in that setting, probably I can ask for a chest X-ray also. So troponins are the key here. So based on the ECG and investigations, especially ECG and troponins, I can risk stratify the patients. I'm going to stratify the risk. So what is the risk of a patient of having a cardiac chest pain? So I'm going to tell whether the patient is having low risk, patient is having intermediate risk for having a coronary syndrome, or the patient is having a high risk of having a coronary, acute coronary syndrome. So whether how to approach from this is a highly independent thing, and each and every institute has some different kind of approach in this. Suppose any high risk patient, it's better to treat it like an ACS, and you're going to take like an ACS. Suppose if a low probability disease, then you can probably think about outpatient kind of a treatment. You can discharge and review kind of an approach if possible. So that's one way you can do. Suppose if you're having a intermediate probability of having a disease, then probably you can think about doing a non-invasive investigation. And all these things are highly individualized. Non-invasive approach. If it's a high risk, then you can try an invasive approach. Invasive approach means we are doing a coronary angiogram. That's what we mean by invasive approach. You can think about an invasive approach. If an intermediate probability, then you can think about a non-invasive approach. For example, which will come under a high probability. For example, if the clinical picture, the clinical picture is very, very sure that you're having an ACS, which I'll be discussing in some time, or if the ECG is showing features of acute coronary syndrome, or if the patient is having a troponin elevation. So all this will probably come under the setting of high probability for having the disease. And low probability, maybe the clinical feature is typical of a non-cardiac chest pain. And if the troponins are negative and the ECG is completely normal. So in this setting, you can think about a low probability of the disease. So in that setting, you can even think of outpatient related management. You can discharge the patient and review back if needed. Intermediate probability means somewhere in between. Like you might have pain that may tell you an ACS, but still patient is having a normal ECG or a troponin is negative, or you might have isolated troponin elevation, but patient is having a kind of a non-cardiac chest pain, or chest pain that is not correlating with your acute coronary syndrome. So, or ECG is showing some problem, but troponin is negative. So this kind of confusing approach, you can think about doing a non-invasive approach, but again, it depends. So on how you're going to really go about that. So this is how you're going to approach a chest pain in the emergency department. So now once you approach the chest pain in the emergency department, you're going to characterize the chest pain. So as I told you, whenever the patient is having chest pain, it could be a chronic chest pain or acute coronary syndrome. Chronic chest pain can be a chronic stable angina, which we discussed some time back, but I'm going to discuss once again. It could be a chronic stable angina, or it could be other variants of angina. So that's called a variant angina. So if it's an acute coronary syndrome, as I told you before, it can be a ST elevation myocardial infarction, that is always referred to as ST ACS, or it could be a end-STEMI unstable angina complex, which is commonly referred to as NST ACS. Non-ST segment elevation, acute coronary syndrome. Chronic stable angina, as I told you multiple times in the past, it's going to have a fixed plaque, and a stable plaque. So the pain, the troponins, the ECG, everything will be stable. It will not show any changes. I mean, even if they show changes, they will be same. They'll not be having any dynamic changes. That's the key here. As far as your acute coronary syndrome is concerned, definitely you're going to have a dynamic changes, in the sense like what are the things that are going to be dynamic? The pain is going to be dynamic, the troponins will be dynamic, it show rise and fall, and ECG will be dynamic, showing some new changes. Imaging, echocardiogram will be dynamic, it will show some new regional wall motion abnormality. So everything will be dynamic in nature. That is because of one reason: the plaque here has become unstable and it has ruptured. It's an unstable plaque here. We have discussed already, right? It's an unstable plaque. As far as the differences between STEMI and NSTEMI is concerned, as I told you multiple times, once again in the past, let me discuss for one final time. It's going to be a single vessel disease, 100% occlusion, which means a full occlusion, and it's going to be presenting in a very acute fashion. And because of the acute presentation, they are not going to have much collaterals, and all these things will give rise to a point where you're going to have a focal and a transmural infarction. A full thickness infarction. If you draw the heart, you can clearly see that this patient is going to have a focal and a transmural infarction. And this transmural infarction is the reason why you get the typical ECG change. That's going to produce the ST elevation due to the nature of the injury current, which you have discussed already. And this ST elevation can progress to produce Q waves, and that's why this MI is also referred to as Q wave MI. Most commonly, they'll progress to produce the Q wave because of the full thickness infarct they get. As far as the NSTACS is concerned, we know it's a multi-vessel disease with not complete occlusion, but a subtotal occlusion. It will not have a total occlusion at any cost. And this may present in a very subacute, even in a chronic way. And because it's having time to produce the collaterals coming in subacute fashion, it can have a little bit of more collaterals. Because of that, all these features, they are going to have a multifocal because of multivessel disease. And at the same time, they'll be having subendocardial infarction because of more collaterals, and it's not a full thickness, full occlusion. So you can have a subendocardial infarct only. So one other reason why you get a multifocal occlusion is the fact that because apart from the multivessel involvement, they are going to have something called a phasic distal embolization. Phasic distal embolization, which will tell you very clearly that the patient is having a multifocal infarct, and that's one of the reasons. So if you want to draw here, so the patient will be having a multifocal subendocardial infarct at multiple different places, and of course they are going to produce ST depressions and T wave inversions ECG, which very rarely, maybe 5 to 10% can progress to Q wave. That's why this is also referred to as a non-Q wave myocardial infarction. But very rarely they can progress to a Q wave. So that's why it's called a non-Q myocardial infarction. Be very clear about that. Don't write anything wrongly there. Fine. So apart from that, if you take the troponin elevation is going to be maximum in the setting of STACS, whereas it's going to be either minimally increased or normal in the setting of a NSTACS. Remember, previously we called increased troponins as NSTEMI, and if the patients are having normal troponins, we tend to call it as unstable angina. But such a difference right now, it's not going to help you at all, because the treatment is going to be the same for NSTEMI or unstable angina. The approach is going to be the same. So the goals of treatment is very simple. In STEMI, it's completely occluded, so you have to reopen the vessel. That's why reperfusion is the goal here, which can be achieved either by fibrinolysis or you can achieve by a PCI. Whereas the goal in NSTEMI and stable angina, that is NSTACS, is to prevent the further progression of the occlusion, thrombus. So in that setting, you're going to use anticoagulation as the mainstay. And in fact, plus or minus, you can go for a PCI if it's a high-risk disease. But the most important is the reduction of progression of thrombus. And because it's partially occluded now, you can go for a fully occluded set. To prevent that, you have to give anticoagulation. At the same time, if needed, you might be needing to open up the vessel in the form of PCI as well. But remember, thrombolysis is not indicated, or in fact contraindicated in the setting of a NSTACS. And at the same time, you know, the clot will be more of a fibrin clot, which I told you previously. It's supposed to be a little red. It's called as a red clot. It's not every clot will be red only. So it's called as a red clot because of more fibrin. And here it's going to be more of a white clot because it consists of more of a platelets. And that is also the reason why thrombolysis is very effective in breaking down this fibrin. And if somebody asks you what is the best time to do a thrombolysis, it's to do within 3 hours. This is the best time to do thrombolysis, where the clot will be fresh, not organized, autothrombolysis has not gone. And if you lyse at that point, it's going to break down very easily. So that's why you have to do the thrombolysis, if at all possible. Best time is to do within 3 hours. But of course, thrombolysis you are not going to do here. And since it's a platelet clot, your antiplatelet agents like GP2B3 inhibitors. GP2B3 inhibitors are going to be very, very helpful in NSTACS, even though it can be helpful in STACS if you're doing a PCA. Apart from the fact that if you're doing a PCA, you can use a GP2B3A, it's not beneficial so much in the setting of a ST segment elevation myocardial infarction. So the goal here is very simple. It's reperfusion, open up the completely occluded vessel, and goal in the setting of NSTACS is to anticoagulate and prevent the progression of the thrombus. Ashwin is asking, what is PCA? Can anyone expand what is PCA for Ashwin? Ashwin, which year you are in? Which area are in, Ashwin? Fine layer. Okay. It's percutaneous coronary intervention. Okay. Thank you. So it is PCI. Cool. That's in layman's terms, you can call it as stenting also. Fine. I think that must be enough. So we have discussed about the chest pain and STEMI and NSTEMI and difference between STACS and NSTACS also. The variants, the most important variants is the Prince metal angina. I think if I'm sure, I've discussed about the Prince metal angina to a large extent in the ST elevation area itself. There itself, I have given the differential diagnosis where I have told about the Prince metal angina in detail. So as far as the chronic stable angina is concerned, if you take the pain in the setting of a chronic stable angina, it's going to be fixed. What I mean by fixed, so I can draw the graph like this. So which means whenever they get an exertion that is beyond the threshold that the patient used to get. So at every time they get, they do an exertion that is beyond their particular pain threshold, they used to get a pain. And you can see it is absolutely fixed amount of pain, which means there is no increase or decrease in the pain. At every time they get pain in association with exertion, and the amount of pain they get is also very fixed. There is no much change in the intensity of the pain as well. So that is the definition of a angina. In fact, they will get chest pain. Usually that, it will be an ischemic chest pain only. You can write it's an ischemic chest pain. That will generally last for less than 10 minutes. It will not be lasting for more than 10 minutes. And of course, they will be increased with exertional activity and reduced with rest or nitrates. This is really, really important. If it's reduced with rest or nitrates, how fast it should reduce? It should reduce within 30 seconds to 5 minutes. Usually within 5 minutes, they will have a complete response to NTG or by resting. So if something violates this principle, then you are going to have a problem. So if all 3 out of 3 are there, then it's called as a typical angina. If only 2 out of 3 are there, we are going to call it as an atypical angina or atypical chest pain. If only 1 out of 3 is there, it's called a non-cardiac chest pain. Non-cardiac chest pain. These are the definitions of chronic stable angina. On the other hand, ACS pain will be completely different. If you want to know the clinical picture, how an acute coronary syndrome is going to present, more often they will be having a chest pain of a longer duration, generally more than 15 to 20 minutes, in fact more than 30 minutes. Remember, having a longer chest pain doesn't mean it's only an acute coronary syndrome. Many non-cardiac chest pain also can produce this kind of longer chest pain, or a very extremely short chest pain, like 1 second, 2 second kind of a pain, or very long chest pain, like days together, 5 days, 6 days of chest pain. It can be caused by non-cardiac conditions also. Like you have a fracture of the rib, you're going to get continuous chest pain only. So that doesn't mean only it's an acute coronary syndrome. The chest pain of longer duration has a higher risk of being an acute coronary syndrome. So ACS, chest pain more than 15-20 seconds, or the patient may have some kind of a rest pain. That's really, really important. And one of the important features of an acute coronary syndrome. It could be any acute coronary syndrome, because a chronic stable angina pain will always happen with exertion only most of the times. If the patient is having a rest pain, then that really indicates, like a very serious disease, to be honest. Or if the patient is having a new onset chest pain, that could be a probable ACS. New onset means within the last, like 1 week, or maybe in the last 1 month, maybe in the last 48 hours, maybe in the last 24 hours, maybe in the last 1 hour. So that's what we refer to as a new onset chest pain. But on the other hand, chronic stable angina should not be diagnosed unless and until the pain is persistent for more than 2 months. So only in that setting, you will be calling it as a chronic stable angina. So whenever the patient is having a new onset chest pain that is defined as pain within the last 1 month that started with and increasing with intensity, then definitely that is probably an ACS. It could be evolving in a subacute fashion. Small thrombus slowly evolves over a period of time. So new onset chest pain, definitely it's likely to be a acute coronary syndrome. Or you have this dynamic kind of a pain. So we call that dynamic kind of a pain is like a crescendo sort of a pain. So what do you mean by crescendo sort of a pain? The pain increases with each and every subsequent attack, and the frequency will be more and more over a period of time. So here you can see the pain is increasing continuously over a period of time. We take the time in the x-axis and the pain scale on the y-axis. The pain is increasing over a period of time, and sometimes it can be associated with exertion, but most of the times less than the threshold exertion itself will cause a pain in the setting of a acute coronary syndrome or an unstable angina. And sometimes you can, conditions, for example, in the second category, I showed you like the patient has got a pain without exertion also. This is an example of a rest pain. So getting a rest pain, increasing intensity of the pain, or getting pain at more frequent intervals at reduced work threshold. So all these things could be a probable evidence of having an acute coronary syndrome. So the moment you call it as acute coronary syndrome, you should not think the patient will have only 2 hours or 3 hours of chest pain, which is a very, very common mistake that everyone does, thinking that only 2 hours, 3 hours, because the word acute is the most confounding factor here, thinking that the chest pain will be there for 1-2 hours only. No, not like that. It can have for few weeks also, which means the MI is slowly evolving over a period of time. So you have to be really careful. That's why you have multiple different diagnostic ECGs like Wellens syndrome and all. Wellens syndrome is a critical ischemia. I didn't tell you it's an MI. It's a critical ischemia of the LAD, which you have discussed with the ECGs. So go through that ECG. I told it's a critical ischemia of the LAD, can result in STEMI, a frank STEMI within a short period of time. So a lot of evidences are there to tell that the patient's particular chest pain is having a high risk feature. So apart from that, if the patient is coming with hemodynamic instability and a chest pain, like for example, shock, bradycardias, you have to really worry about being acute coronary syndrome. Or the patient is coming with a pulmonary edema and a chest pain. Or the patient is coming with a tachyarrhythmia and a chest pain. Especially if they have ventricular tachyarrhythmias, then there is a high probability of the chest pain being a acute coronary syndrome. So these are some of the pointers towards that the chest pain, towards the ACS, if the patient is coming with a chest pain. So you have to be very clear about that. So what is ACS and what is not ACS according to the clinical background. Fine. So with this understanding, let us go and start discussing about the acute coronary syndrome to start with. As far as acute coronary syndrome is concerned, you have different types of acute coronary syndrome. As I told you, you have NST ACS and ST segment elevation ACS. But more importantly, as I told you multiple times in the past, acute coronary syndrome should be basically first stabilized. Because here you think the patient is having an ACS, which means it's an emergency condition. So you have to try and stabilize the patient first. That's the most important thing. As far as the stabilization is concerned, you have to control the pain first. Controlling the pain is one of the most important things as far as the acute coronary syndrome is concerned. And in that setting, you're going to use nitrates as one of the important treatment. You can use IV NTG or NTG continuous infusion. Suppose if the nitrates are not really responding to responding well, patient is not responding well to nitrates, in that setting you can add additional opioids for controlling chest pain. In this setting, we typically use morphine for that perspective. So how nitrates and opioids work? They increase the coronary blood flow. At the same time, they're going to reduce the preload to the heart. Because of the more workload on the heart, you're going to get chest pain. Because the patient gets reduced work, because they cause venodilation, they're going to reduce the workload of the heart. You're going to get reduced pain. One problem with morphine is they can delay the antiplatelet effects of clopidogrel, but that's a different story. But nevertheless, we still use morphine as a very common agent in the emergency as well as in the ICU. Then next thing is oxygen, whether you can give oxygen or not. Remember, oxygen is given only if the saturation is less than 94%. Otherwise, we don't really give oxygen, even though there are some guidelines which tell 90%. But it's better to give oxygen when the saturation is less than 94%. Otherwise, we don't really give. Then we have beta blockers. Beta blockers have a very good role in the setting of acute coronary syndrome, especially in the setting of unstable angina. They reduce the progression towards myocardial infarction, because we know unstable angina, your troponin will be negative. Myocardial infarction, your troponin will be positive. This is the major difference between unstable angina and myocardial infarction. First of all, what do you mean by unstable angina? Remember, any high-risk chest pain, you have a high-risk chest pain in the sense like your chest pain features are typical of an acute coronary syndrome, but they have a negative troponin. So this is the perfect area where you can diagnose as a unstable angina. This is a very, very good example for diagnosing unstable angina. High risk chest pain, features that are typical of an acute coronary syndrome, but they have a negative troponin. This is what we called as an unstable angina. So giving a beta blocker can reduce the progression from unstable angina to the chest pain. Reduce your camera. Is it anyone seeing blood? I don't think it's blood. I think it's your screen resolution that has to be adjusted, Godfrey. Adjust your camera in the sense, what adjustment do you need in the camera? I think I'm seeing perfectly. I don't think anything is blurred. Okay, thank you. And I think Godfrey has to adjust his like resolution on the internet speed only. So I think here it's fine. I'm having a full Wi-Fi now, so I don't think that must be a problem. Okay, so we're going to start with beta blockers. Beta blockers are going to reduce the conversion of unstable angina to frank myocardial infarction. So which means you can tell in any ways. So they can reduce the ischemia overall. How they reduce the ischemia is by reducing the workload on the heart, because they're negative inotropic agents. They reduce the myocardial oxygen consumption, myocardial oxygen demand. And they also reduce the conversion of unstable angina to myocardial infarction. And even if the patient is having a myocardial infarction, they reduce the size of the infarct to a great extent. Clear? Even if you start in the myocardial infarction, they reduce the size of the infarct. At the same time, if you start in the STEMI, they reduce the risk of ventricular tachyarrhythmias, because one of the important reasons for death in STEMI is ventricular tachyarrhythmias, like ventricular tachycardia and ventricular fibrillation. So they reduce the risk of development of ventricular tachyarrhythmias. Even the only problem is they slightly have increased risk of developing cardiogenic shock and pulmonary edema, being negative inotropic agents. So there is a huge controversy with regards to whether to be used in an ACS or not. But current idea is to use beta blockers in the setting of ACS, provided you have hemodynamic stability. If you don't have any contraindications for its use, then not a problem. The standard drug that we use is metoprolol. That's the standard drug that we use most of the times, where we give 25 to 50 milligram of metoprolol, 6th hourly to 8th hourly. Beta blockers, second point, Indra is asking. They're going to reduce the conversion of unstable angina to a frank myocardial infarction. Which means, simple. We can give amiodarone right for ventricular tachycardia. See, I'm telling, they are reducing the risk of development of ventricular tachyarrhythmias. If they develop ventricular tachyarrhythmias, then fine. I'm talking about reducing the risk of development of ventricular tachyarrhythmias. Why you want to give amiodarone for that? And such a toxic drug. If beta blockers are very helpful. Here, the beta blockers are having a prophylactic role. Yesterday, if you take the beta blockers section in the antiarrhythmic drugs, I have told very clearly the same point I've reiterated multiple times yesterday also, that they reduce the incidence of ventricular tachyarrhythmias if it's used in a STEMI patient. Clear? So I told you many times. So they reduce the risk, not they stop the ventricular tachyarrhythmias if they have already happened. So once the ventricular tachyarrhythmias have happened, my choice of drug will be either a lignocaine or probably an amiodarone. I'm not going to use beta blockers once the ventricular tachycardia has set in. We're talking about the prophylaxis here. So we're going to start with metoprolol around 25 to 50 milligram dose. You can give as a BD dose or even a TID dose. So I can give BD dose or probably a TID dose, or even you can prefer a QID dosing also. The dose depends on patient to patient and from cardiologist to cardiologist. But this is the standard dose to start with, 20 to 50 milligram, which can be given 2 times, 3 times, 4 times. It depends up to you. But remember, the dose can be titrated based on the heart rate. Remember, your heart rate should be maintained somewhere around 50 to 60. So this is the target heart rate. And if they go for bradycardia, then it's better not to give. So in our hospital, we keep a cutoff of target heart rate of 60. So if it goes below 60, we generally stop. But many guidelines tell you maintain a target heart rate of more than 50 to 60. That is the, I'm not telling it should be 50 to 60. It should be more than 50 to 60. That's the target heart rate after starting the beta blockers. So whether to start oral or IV beta blockers, in general, we prefer using oral beta blockers only. The guidelines are extremely strong. But on the other hand, if you want to use IV beta blockers, can be done, especially if the patient is suffering from hypertension. So if the patient is having hypertension and acute coronary syndrome, you can use an IV beta blocker. Or if the patient, plus the patient should have no heart failure. That's really important again. Plus no heart failure. So if this criteria is satisfied, then you can give IV beta blockers. But apart from that, we generally prefer giving an oral beta blocker only. In our institution, we generally use an oral beta blocker. We don't give an IV beta blocker, to be honest. Because IV beta blockers, many cardiologists are very scared because they can cause pulmonary edema and decomposition very rapidly because it's already failing heart. So beta blockers are beneficial, but still, where to use and how to use, and again have to be very, very careful because they are negative inotropic agents. In such a situation, it can result in pulmonary edema. Be a little careful. So oral beta blockers, absolutely fine. I don't have any problem at all. Okay. So I told you the standard beta blocker contraindications yesterday itself. So Indra is asking what are the contraindications of beta blockers in ACS. I told you the standard beta blocker contraindications already. So hereafter, if I tell contraindications of beta blockers, you refer to the previous antiarrhythmic table, which I have told yesterday itself. I have given each and every contraindication as a list. Then, is there any alternative to beta blockers? Alternative is non-dependent calcium channel blockers like verapamil or diltiazem. They have a very poor evidence for their use. You can use if beta blockers are contraindicated. So if the beta blockers are contraindicated, you can use calcium channel blockers like verapamil, diltiazem, but remember they have an extremely poor evidence for their use. They don't provide a very decent benefit. Yes, we are talking about 25 to 50 milligram per dose. Per dose is what we are talking about. Apart from the beta blockers, we have the dual antiplatelet therapy, isn't it? So that's what we have to start with. So as far as the DAPT is concerned, what is DAPT? You're going to start with aspirin plus any one platelet P2Y12 inhibitor. So we know the standard dose of aspirin is 325 milligram. This should be a loading dose per oral, and this should be followed by 75 milligram per day. Or some books will give 81 milligram per day also, but I don't think in India 81 milligram per day is available. You are going to give only 75 milligram per day. The initial loading dose, then followed by 75 milligram per day, and it should be continued indefinitely. And remember, the aspirin that you're going to start here should be a immediate release form. It should not be a entry coated form. That's really, really important. You have to release immediate. You have to give immediate release form. And most often it's a chewable form of aspirin. You have to chew the aspirin rather than swallow the aspirin. If you want to know, the brand name Dispirin will do good in this setting, but don't start ecospirin. Ecospirin is an entry-coated aspirin. It is given for a longer run. So remember, after starting the 75 milligram per day that you are giving, can be a entry-coated aspirin, doesn't matter. But the 325 milligram per day that you are giving should be a immediate release aspirin only. Because in ACS, you wanted this to work immediately to prevent the further progression of the thrombus and further embolization. So that's really, really important. So you give an immediate release aspirin. Don't give ecospirin in that setting. And as far as the platelet P2 Y12 inhibitor is concerned, you have multiple different drugs. You have clopidogrel, you have prasugrel, or you can give, yes, this is single dose. Loading means always single dose only. Prasugrel and ticagrelor. 3 drugs are there. And even 4th drug, cangrelor, is also there. Not a problem. But as far as the clopidogrel is concerned, I'm going to initially give a dose of approximately 300 to 600 milligram. But in India, we follow a standard dose of 300 milligram because the Indian patients are known to metabolize a little slowly, and at the same time, they have some polymorphism cytochrome enzyme. So the risk of bleeding might be a little high in these patients. So we use a dose of around 300 milligram to be a little careful. Then this will be followed by 75 milligram per day dose. This is a standard dose of clopidogrel. As far as prasugrel is concerned, so usual dose of prasugrel is 60 milligram loading dose. This will be followed by 10 milligram per day. That's the standard dose of prasugrel. Then as far as ticagrelor is concerned, we are going to give 180 milligram of loading dose, and this will be followed by 90 milligram 2 times a day as a standard dose. So remember, you are going to give any one of the P2Y12 inhibitors. You're not going to give 2 or 3. You're going to give only one of the P2Y12 inhibitors which I have discussed, and the current choice is towards ticagrelor because clopidogrel has some unreliable action. That's why current choice is always going towards ticagrelor only, where you give 180 milligram, then followed by 90 milligram 2 times a day. Prasugrel has some unique contraindications that we have to know, which I've told some time back. Weight less than 60 kilogram. You can give 5 milligram prasugrel in that setting, but still it's better to avoid prasugrel as a whole. And if the patient is having age more than 75 years, high risk of bleeding, and at the same time, if the patient has history of stroke or a transient ischemic attack. So again, it's contrary because certain studies, early studies have proven that prasugrel is associated with a higher risk of stroke and TA. So we generally avoid prasugrel in the setting where the patient is having a stroke or a transient ischemic attack. One biggest problem that you're going to face after starting with aspirin or P2 vital inhibitor is the fact that if the patient needs an urgent cabbage, that is coronary artery bypass grafting, there is some problem because doing a cabbage may cause a severe bleeding if the patient is already on these drugs. So apart from that, these drugs are good, you can start with, but only problem is like they might cause some problem, especially when you're planning for an urgent surgery in the setting of MI like cabbage, or probably you're doing a complication surgery. Like if the papillary muscles have ruptured, you want to repair that, or you want to do a mitral valve replacement in that setting, this can result in certain complications like bleeding. Apart from that, they are really, really good drugs. So what are the properties of these drugs? So let us see what are the antiplatelets that we are going to use in the setting of a STEMI. I generally tend to give this table every time because this will help you understanding a lot of other stuff as well. So first, what we can do is we can talk about the platelet. So this is a platelet I'm starting with. And in the platelet, you're going to, once the platelets are activated, you're going to use the COX pathway where you have something called arachidonic acid. This arachidonic acid will enter the COX pathway to produce multiple compounds, but in the platelets, the thromboxane A2 is going to be more important. And once this thromboxane A2 is released, this thromboxane A2 is going to act on the TXA2 receptor, thromboxane A2 receptor. Once it acts on the thromboxane A2 receptor, it's going to cause some peculiar issues, which we'll talk about that in some time. So Nilashis wanted to expand DAPT. DAPT stands for, where is that? Dual antiplatelet therapy, or you can remember as a double antiplatelet therapy. So you aspirin plus one of the P2 vital inhibitor, so it's dual drug therapy. Then once you start with, I got deviated. Okay, so thromboxane A2, once it activates thromboxane A2 receptor, you're going to result in some peculiar changes. And similarly, once the platelets are activated, you are also going to release this substance that is the ADP, so which acts on the ADP receptor. You know what is this ADP receptor called as P2 vital receptor? There are many types are there, but P2 vital receptor is very important. This is also referred to as ADP receptor. And you have thrombin that can come from the platelets, and it can come from other sources also. Clear? So thrombin can work on something called PAR receptors, that is protease activated receptors. And this thrombin can come from other external sources also. So it's not like thrombin is coming only from the platelets. So once you activate any one of these three receptors, you have activated the thromboxane A2 receptor, you have activated the ADP receptor, you have activated the ADP receptor, or you have activated the PAR receptor. Whatever may be the fact, activation of all these three receptors is going to give rise to a standard signal that they're going to stimulate something called a GP2B3A receptor. So that will result in unwinding and activation of the GP2B3 receptor, which is going to result in cross-linking of the fibrin. So once the fibrinogen is cross-linked, and this will bind to another GP2B3 receptor, and this will bind to another GP2B3 receptor of the another platelet. And like this will bind to another GP2B3 receptor of another platelet. Like this, fibrinogen can bind with multiple GP2B3 receptors because it's a huge molecule. 100, 200, 300 platelets can be bound. So that is going to result in something called a process called platelet aggregation. So which means if you see all these entities, maybe the thromboxane A2, maybe the COX pathway, maybe the ADP, maybe the thrombin, PAR receptor, P2Y12 receptor, all these things are, in fact, the GP2B3 itself are involved basically in platelet aggregation. They are that's the most important step. Apart from this platelet aggregation, you have another important step that's called platelet adhesion, which is basically done by GP1B9 pathway. That's not really very important for us because we only wanted to stop the platelet aggregation. That's most important. So we know that this platelet GP1B9 receptor is going to link with a particular kind of a factor called as 1-Lebrun factor that is going to adhere to the, it's not going to adhere to the endothelium. It's going to adhere to the endothelial collagen. So the collagens will be exposed because of endothelial damage. So they're going to adhere to the underlying endothelial collagen. So the collagen 1-Lebrun factor GP1B9 association is what we refer to as a platelet adhesion. Clear? So whenever you have a congenital deficiency of GP1B9, what is that syndrome called as? It's a very easy one, isn't it? So it's a simple second year kind of a stuff. Bread and butter. Yes, that's called as a Bernard-Solier syndrome. Bernard-Solier syndrome. So, or you can get problems of platelet adhesion with 1-Lebrun disease also. So 1-Lebrun disease can also produce problems of platelet adhesion, but problems of aggregation can happen due to deficiencies of GP2B3. So the deficiency of GP2B3 is what we refer to as something called a Glanzmann's thrombasthenia. We know that. And on the other hand, there are some multiple drugs that can work. For example, there are COX inhibitors like aspirin. Aspirin works by blocking the COX in the thromboxanate. Remember, the action of aspirin is irreversible, which means throughout the life of that particular platelet, the COX will be blocked. At the same time, aspirin doesn't only block the COX, aspirin can also reduce the platelet degranulation. They can also reduce the platelet degranulation. For that reason, also aspirin is being given. Clear? Aspirin is a non-selective COX blocker. So it will block both COX1 and COX2. You have selective COX2 inhibitors, that is different. But in the platelets, COX1 is more important. So you can consider to be COX1 here. But inflammatory is different, that is COX2. We're not going to discuss about that right now. Okay. Anyways, and there are a lot of drugs that can block the thrombin receptors also. These are called as PAR receptor inhibitors. You have PAR receptor inhibitors as well. So if you block the PAR receptors, that drug is called as Vorapaxar. Even though it's not very famous, you have to know the name of the drug. So any other new drug that comes in the future also will have the name of Paxar only. So that's Vorapaxar. And you have a platelet P2Y12 inhibitor. I think we can remove that. Okay, platelet P2Y12 inhibitor. So this is what we have been talking about. You have many drugs. To start with, ticlopidin was initially used, which was banned right now because of its higher risk of producing a thrombotic thrombocervinic purpura. Then we got clopidogrel. Then we got prasugrel. Then we have the modern drugs like ticagrelor and a cangrelor. We have a lot of modern drugs like this. So these are the 4 drugs that we use right now. Remember, clopidogrel, prasugrel, and ticagrelor are basically oral drugs, whereas cangrelor is going to be an IV drug. So it's used only in selected purposes. So clopidogrel was basically a prodrug in the sense to convert to active drug, active form. Prodrug, to convert it in active form, you need a cytochrome enzyme called CYP2C19. So 2C19 is the one that converts clopidogrel from prodrug form to active drug form. But remember, this conversion is only 15%, but 85% of the clopidogrel is going to become inactive normally itself. And this 15% is enough basically to exert a proper clinical action. But the problem doesn't come at that point. The problem will come the patient who are having a cytochrome polymorphism. If they are having slow kind of an activity, suppose the activity is still there, but they are very slow. Polymorphism means I'm talking about slow converters. Your 2C19 activity is very slow, then majority of the clopidogrel will be shunted towards the inactive form, and your amount of active form that will be available will be less in the setting of a this CYP2C19 polymorphism. So that's a little important to understand. So which means this is what we refer to as something called a clopidogrel resistance, and it's very common in the South Asians, especially in South Indians also, like those who are living in the southern states of the country might experience a lot of this kind of cytochrome polymorphisms. Because of that, your availability of the active clopidogrel will be less and the inactive clopidogrel will become higher. So that's what referred as a clopidogrel resistance. To combat this, they have discovered a new drug called prasugrel. Prasugrel also is a prodrug and gets converted to active form by the same cytochrome 2C19. Now you can ask, sir, what is the advantage of this particular thing? So why we wanted to really get a prasugrel if this is also getting activated by 2C19? But the problem, the good thing about prasugrel is it has no other option. 100% all the prasugrel should be converted to active form only by 2C19, which means it has no other alternative pathway. So that's the disadvantage here. So which means you are using a disadvantage into an advantage. Suppose if the patient is having polymorphism, which means the patient is having slow conversion, that's well and good here, because prasugrel still can't go anywhere. It has to get converted through this pathway only. So which means this polymorphism and slow pathway is actually beneficial here, because they are going to increase the half-life of the drug, and they can form active drug in a very slow way for a longer period of time that increases the half-life of prasugrel. So that is the reason if you take prasugrel, where is that? The dose of prasugrel you can see is the least compared to all the other drugs. Compared to clopidogrel, compared to ticagrelor, the dose of prasugrel is extremely less. The reason is that only, because even if the polymorphism is happening, it has to go through that particular direction only. So even if it is slow, it's good. So it's going to help in the cytochrome polymorphisms. And I told you the contraindication of prasugrel already. Then ticagrelor and cangrelor are directly active drugs. They don't have any problem at all. So they don't have any issues at all. They are directly active drugs, so you can give them. So they're not pro drugs. They don't need any conversion business like this. So current choice is towards ticagrelor only, which is available in the brand name called Brilinta, which is very commonly used in India. Clopidogrel, you have different brand names: Clopilet, Clopitab, Plavix, so many different names are there, but original brand is Plavix. Okay. As far as the early part of the triage is concerned, we have used it. Then there are other things that you can do. For example, you can use statins. Whether to give statins at the onset of ACS during the DAPT itself, or whether to give a little late, early, is highly controversial. But what they're suggesting is to give statins as early as possible, which means there's no fixed time like DAPT that you should give at this point. But statins can be given any time, a little later also, no problem. But they're trying to give as early as possible. And of course, because ACS is a ASCVD, you have to use something called a high intensity statin. I'll discuss about this in detail later on, but let me tell you what is high intensity. In India, you use either a atorvastatin at a dose of 40 to 80 milligram. The higher is better. And you're going to use rosuvastatin at a dose of 20 to 40 milligram. The higher is better again. So if you use the higher dose, that gives the best response. As far as statins is concerned, you try to increase the dose. Don't try to decrease the dose. If you take any other drug like insulin and all, you try to reduce the dose as much as possible. So what is the best dose for the patient? But statins, as far as the patient is tolerating, give the maximum dose as possible. Giving more dose is always beneficial as far as statins are concerned. So plus or minus, you can add ezetimibe if there are some certain indications. That plus or minus only, but statins is mandatory in any acute coronary syndrome, or in fact any atherosclerotic cardiovascular disease. But ezetimibe is optional. You can use if you want, but they have proven some good mortality benefit and improved survival with ezetimibe. If you are going to add statins, high intensity statin only single dose, or for how many days? Not a single dose. You have to continue forever. Once the patient gets an ASCVD, high intensity statins are forever. How much ever dose they are tolerating. Suppose I am able to tolerate 80 milligram of atorvastatin, I will continue with 80 milligram of atorvastatin even for entire life. Statins are always beneficial. Take my word. If there is one drug that you can give for lifelong, irrespective of the disease also, it's statin only. It's going to be unequivocally beneficial. except for the fact if you consider that some side effects are there with statins, but even though that is not very important compared to the benefit it's going to provide, statins are always beneficial. And next is ACE inhibitors or angiotensin receptor blockers. Usually we start if the patient is in heart failure, but you can start in all patients. Better to start in all patients. Better, all patients starting is better, but especially if the patient is having heart failure. If the patient is having heart failure defined as EF less than 40%. In this setting, it's much better to start with your ACE inhibitors or ARBs. And statins have multiple advantages. I didn't tell actually. Statins have multiple different advantages. Like for example, statins are highly beneficial if you're using a coronary angiogram, because statins can partly reduce the risk of contrast-induced nephropathy also, because when you use a contrast in the setting of coronary angiogram, can reduce the risk of contrast-induced nephropathy, and at the same time it can reduce future ischemic events, and at the same time it can reduce something called a peri-PCA myocardial infarction, because there is something called a post-PCA or a peri-PCA MI, which can happen after a PCA. So statins are known to reduce that also. Statins have multi-dimensional benefit. So not only for reducing the future ASCVD we are giving, it can also reduce the procedure-related myocardial infarctions. It can reduce the contrast-induced nephropathy risk, and it can reduce further future ischemia, which I've told you multiple times. Statins are unequivocally beneficial in ASCVD patients. The ACE inhibitors or ARBs can be started if everything, I mean, for all patients you can start, which is better. Usually we start around 24 to 48 hours. Once the hemodynamics are stable, once the renal function becomes stable, we start with ACE inhibitors and ARBs, but not immediately needed. But you can start once the patient is okay and stable for the next 24 hours. Very strong indication if the patient is having heart failure and EF less than 40%, or if the patient is having diabetic kidney disease. Definitely strong indication. DKD, especially diabetic nephropathy, one of the important things. GP2B3 inhibitors are also used in procedure-related myocardial infarction. No, procedure-related myocardial infarction will be treated in the same way as a myocardial infarction. GP2B3 inhibitors are used to reduce the procedure-related events, which means GP2B3 inhibitors are more of a prophylaxis kind of a situation, where you wanted to prevent the risk of procedure-related myocardial infarction. So that is what you're going to do with ACE inhibitors and angiotensin receptor blockers. Okay, so you have a lot of entities that you can use as a triage. Okay, so now once you have finished the early assessment and management, then it's better to go for that, how to treat a NSTEMI unstable angina complex, that is called NST acute coronary syndrome, NSTEMI unstable angina. So before that, I'll just come back in 2 minutes to check everything is well or not. Just 2 minutes. So we are going to start in a couple of minutes.